Welcome to another episode of Judgment Date. As you know, we have been doing these programs especially because of the lockdown, and we've been exploring inter alia the economic, the legal, and the health implications of COVID, how it affects us, trying to help those who watch these particular programs through what has been a very difficult and complex situation, and trying to give them some sense of where we are going with it. And it's a great delight this afternoon to welcome Dr. Leon Geffen, who is running an old age home facility at the moment, is also on the WHO panel, which advises on these facilities and the question of COVID and older people, and therefore is particularly well equipped to deal with many of the questions that I want to pose. And perhaps I want to start off, if I may, to ask you, it appeared that in places like Italy, the majority of the people who died were old, and they were old age homes that really, it was almost a tsunami. Why was that?
Dennis, thanks very much. It's not only in Italy, it's in actually countries like Belgium and in France, Italy, as you've mentioned, Canada. More than 50% of all deaths occurred in people who were living in what you're calling old age homes. We use the term in South Africa, residential care facilities.
Okay, I'm sorry for being politically incorrect.
These are amongst the frailest. I accept that. The most frail people in society generally live in these type of facilities. A lot of these facilities over the years have been very neglected in terms of the services that are rendered within the facilities. Services are often rendered by relatively unskilled care workers. There's often a lack of access to good health care within the facilities. And none of these facilities were ever geared towards providing care for a rapidly progressing and spreading disease such as COVID. And probably that's one of the most important reasons why these facilities were most affected. The other reason why a lot of the facilities were very badly affected was that in countries like Canada, there was almost a refusal to admit people to acute care hospitals from nursing homes. A lot of facilities became sort of the decanting points for older people who may have been in acute care hospitals at the time to be sent home into facilities, and therefore allowing the spread of the virus within these facilities at a much more rapid rate than we would have seen around in other community settings, etc. And then once it gets into a facility, the spread is almost uncontrollable because people live in communal settings. They are sharing bathrooms often. They'll be sharing food services. Caregivers lack necessarily the requisite hygiene to hand washing, and they're under-resourced, and that's why why COVID spread specifically in care homes as quickly as it did.
So would it be right to say, when one looks at the total deaths around the world, and including South Africa, that a significant proportion of those have been older people? We can
overwhelmingly. I think that the Italian data shows that has shown that the total number of people, the average age of people dying in Italy was about 82. And many other countries around the world, we saw that what we call the case fatality rate, which is a statistic and measure that's been used widely, the total number of people who die when they've diagnosed with COVID goes up exponentially as for every decade over the age of 60. So we could expect about 20%.
Carry on.
Yeah, we can expect about a 20% mortality in people over the age of 80 who are diagnosed with COVID.
So if COVID, this is not necessarily my view, but when you're older, it's never your view about older people, as I rapidly get there. But what I'm asking is, there's the cynical view, which says, well, if the average age is 82, well, they may have lived to 83, 84, 85 if there hadn't been COVID. But the cost of shutting entire economies and societies down to give older people a year or two more is disproportionate to the cost which is suffered by younger people through poverty, lack of employment, and destruction of the economy. How do you respond to that?
That's not an unreasonable argument, but then we've got to examine countries which didn't have the lockdown and didn't do the things that have been very important to reduce the spread. So we take countries like Sweden, we take countries like the UK in the early stage, and we certainly look at the United States, that despite all the laissez-faire attitude that governments may have taken to the management of COVID in these countries, there was still an enormous spread. There is still a mortality in younger people, and hospitals get completely blocked up and the acute care service get overwhelmed. So no matter whether you took an approach of we'll keep society open or we're going to close society down, the outcomes seem to be the same, and it had the same economic impact. So it seems that the best strategy actually has been in those countries which contained the spread of the virus at a very early stage by going through a rapid and very stringent lockdown. So you look at countries like Singapore, and you look at, for instance, Hong Kong, which have contained the virus in a significant way. Unfortunately, what we know with the virus is that it's rearing its head all the time, that as you're going through a phase of lockdown and containing the virus, and then you're reducing the restrictions, we're seeing the virus rearing its head again. And we're seeing this happening now in Spain. We're certainly seeing significant upticking in the numbers once again in most of the southern European countries. So it doesn't appear that many of the strategies of opening up society are working to contain the virus.
All right, I'm going to come back to that particular point, if I may, but I want to just ask you this. You running an aged care facility in Cape Town have had, I know you told me, unfortunately and sadly, that somebody died on Friday from COVID, but you've had remarkable success in the light of the fact that you're dealing with elderly people, comorbidities, people in the 80s and 90s and beyond. And you've had remarkable success in keeping the death rate down. In fact, to one, as I understand, two. I think one before you arrived to run the facility, and then one now, you say. How come you've had, what's the trick that you've had that's essentially done this extraordinary work?
It could just be luck.
And don't tell me it's luck. No, that's not a good enough answer. You keep on scientists, so give me a scientific answer.
Yeah, you know, the problem is that it can be quite resource intensive. I think the reasons for some of the success was at a very early stage. We implemented very strict PPE measures, so we allowed free access of staff to, for instance, masks, hand sanitizers. We encouraged physical distancing. We did all the issues about education, so all staff were educated. So if I go back to the original outset of the outbreak at the facility that I'm working at, which happened at the last week of April, the beginning of May, there was panic. There was widespread panic, almost fear of staff to come into the facility and provide care. The moment we gave staff, and all staff had access to PPE, but they didn't really understand the ramifications of how COVID was going to spread. What we also knew is that many of the staff were asymptomatic carriers of COVID. Almost 60% of all the staff, because we've tested very widely in the facility, were completely asymptomatic despite carrying COVID. And we know from the global outbreak that asymptomatic carriers are probably the biggest spreaders of the disease. So if we could contain the virus by identifying those people who are positive, we could mitigate the effects and the spread. We also implemented, I think, that we've implemented is data-driven. So we've got good data. We monitor and track symptoms of residents electronically and digitally every day. We track all our caregivers and all our staff, not only the caregivers, but it's the administrative staff, the maintenance staff, the cleaning staff, the laundry staff, the cooks in the kitchen. So it's really important that if one wants to try and mitigate the effects of the virus in a facility, you've got to take the facility as a whole and test and actually quarantine and isolate every single person that you can identify as potentially being positive and having had a contact with them. I think it's
But
also
I also
important.
understand that you've got in your facility, there are doctors who are designated to look after a cohort of patients.
Yes. So very early on, we developed a protocol for assessment of every single resident, and we also developed a protocol for if a person was deemed to be positive, how they would be assessed, and looking at the evidence at the time, and obviously being a very new disease, and trying to understand how COVID affected the respiratory system and the hematological system and the effects that it would have on blood clotting, etc. And as evidence evolved, we adapted our protocols. So that being the case, I think it has had an impact in terms of limiting the effects in the cohort of people that we've been looking after. And all residents are being provided with regular medical assessments, whether they're in the public sector or the private sector. The facility has managed to raise funds to do this. Whilst for the facility it's an expensive exercise, in the overall cost of what COVID has cost the healthcare services, and hopefully we will have the data around that, all the information around that over the next few weeks as we evaluate the program. It's been an incredibly cost-effective program, because of the 28 residents, 2 of whom have passed away, only 2 out of the 28
are actually hospitalized. 28 have had COVID.
28 out of the 180 residents have tested positive for COVID. There could be more residents who are still positive, but they may be asymptomatic at the moment. 2 have passed away, only 2 were hospitalized, and all the rest were treated on the facility with oxygen as they needed. It saved the healthcare services an enormous amount of money. If you take into account the province, the Western Cape province, I think entered into a public-private partnership with the private hospital groups, where they were willing to pay up to, I think, 12 or 13,000 rand per person admitted to an acute care facility in the private sector. I'm not sure how many people were actually admitted to the private hospitals, but that was the order of fees that they were willing to pay. So we assume that a day in hospital for someone who's COVID positive and may be admitted to a high care facility is in the order of somewhere between 5,000 to 12,000 rand a day. We saved the system an enormous amount of money. Now, none of this has been reimbursed by the medical schemes at the moment, and certainly none of it is going to be reimbursed by the state healthcare services. But we've provided a far better quality of care to residents in the facility. It's been cost effective in terms of the minimizing hospital costs, and it's also minimized unnecessary use of medication, and care of the residents has had a very positive outcome on that.
So let me ask you this then. The approach that you've adopted, has that been carried through into the public care facilities in, say, our province, in the Western Cape? No. Why not?
No. Well, there aren't enough doctors. Well, the province needed to then employ doctors at a primary care level to go into each facility and review everyone. The province and whether it's the Department of Social Development, under whom care facilities fall, or the Department of Health, who provide healthcare services, would have had to provide oxygen services on the sites. They would have had to provide access to medication. They would have had to provide access to all the PPE that's required. PPE in the province for most of the facilities was provided now post the first wave of the pandemic that we've seen sweeping through the province.
Well, let me push you on this. Are you then suggesting to me that the province could have done nothing more?
I'm suggesting that the province, I think the province, the Western Cape Department of Health has done a fabulous job in terms of the effect. I mean, we just need to look at the data that's come out from the Western Cape. Yeah. So one of the simple metrics that we can look at is, and maybe I'm diverting a little bit off the topic, but if we look at the Western Cape Department of Health's statistics of COVID deaths, and we look at the MRC's predicted COVID deaths for the province and the total number of deaths in the province, the all natural cause mortality, all cause natural
Natural deaths,
mortality
yeah.
rate, the natural deaths in the province, is about 30% higher than the total number of COVID cases deaths reported from COVID, whereas in most other provinces about 80 or 90% above that. So the Western
So
Cape
just to, sorry, so to
Health,
translate that for my listeners, when I interviewed Glenda Gray about a week ago, she suggested that we, I know it's about 13 odd thousand at the moment, it was about 11 when she and I spoke, and she was suggesting that the death figures were probably closer to the 30,000 mark.
I think we are,
yeah,
I think the MRC data indicates that the total number of deaths is about 35,000.
Yeah.
We can't say that's all due to COVID.
No, she explained that, but she said she thought around about 30,000 would be COVID related, which means that's a massive underreporting, whereas you suggesting that that's far less in the Western Cape.
It's far less underreporting in the Western Cape. So first of all, the Western Cape's data structures are far better. Secondly, the Western Cape very early on implemented a very, very good process of testing and tracing. And it was very well geared up to do the testing and tracing. Unfortunately, there were a lot of hiccups in the early stages in terms of getting tests done through the National Health Laboratory Services. But by and large, the Western Cape Department of Health got things right. They've got the tertiary hospitals like Grootskie and Tygerberg Hospital well geared up. They set up the community hospitals, which are set up at the CTICC to provide oxygen to people. And I don't think most of these facilities most of the community-based facilities were taken up to great extent. But then we must also remember that in the specific instance of residential care facilities fall under the control of the Department of Social Development. The Department of Social Development turned around and says, well, it did not. As far as I'm aware, the Department of Social Development could have engaged with the Department of Health at a much earlier stage, could have engaged with the care facilities at a much earlier stage.
Is this the national department or the provincial department?
Well, the social development, as far as I understand, is a national competence.
Yes, it is.
And the provincial departments are very much under the control of the national department. Whereas the Department of Health, the Western Cape Department of Health is a provincial competence, and they are able to, as long as they're keeping within the major parameters of what the national department's asking, able to manage things on their own, to their own sort of principles and protocols. So the Department of Social Development is very much under the, under the control of the national department, and it's possible that their response was tardy.
Possible. That's a very cautious way of putting it. But I hear you. Can I move on, if I may, because I want to come back to something you said earlier, the danger of relaxing control and getting back to where the other countries are. There's no reason to believe we're so exceptional that we're not going to face this yet again.
No, I don't for one moment believe we aren't going to face it once again. If we look at the RT, which once again is the R0, which is a well-bandied measure of how the infection is spread, we've come down from what could have been an RT from about 1.5, meaning that for every 10 people who are infected, they are infecting another 15 others. Our RT at this point is about 0.7, which means that we are slowing the spread down, but the disease is still spreading. We are not at zero spread. And what we've seen is that in countries such as Spain, which are in their summer months, the moment that we've entered into the relaxation and people are out and about and engaging in what would otherwise be normal activities, going out to restaurants and enjoying all the amenities of summer, we've seen an uptick in the total number of infections again. And this is happening on a global basis.
Yeah, but one hears stories here, for example, of restaurants which are not abiding by the regulations, which are perfectly packed cheek to jowl. I mean, surely if that's going to happen, this kind of level of activity is just going to ensure that we do get a second wave, which may be as ferocious as the first.
Well, I think it's very simple numbers. I mean, if we look at the total number of COVID positives in the country, we're at around about 600,000, I think, at the last number. Mm-hmm. Now, assuming that means that we've confirmed 600,000 are infected through all the testing, and let's just, as an argument, say, well, maybe it's only 1/5 of the total number of people who have been infected, because there are a lot of people who have been infected who don't know they've been infected. But say there's 3 million people in this country who have been infected with COVID. Well, we've got in the order of 55 to 60 million people in this country. We've got another 52 million to go. So there's no doubt in my mind that we're going to be seeing waves of COVID until we either have an effective vaccine or we have an effective treatment, neither of which are in the offing for probably another 1.5 to 2 years.
Well, that's a conservative approach, because some of the people that I've interviewed are suggesting we may get it within a year.
I think that I think that the issue around vaccines is a complex one. First of all, at best, we're probably going to be seeing the outcomes of the phase 3 trials, which are actually the clinical trials. Probably the outcomes, it's now already August, or the beginning of September, let's put it. So assuming we've got another 3 months to go before we start getting a bit of data out, that's going to be, call it the end of December. Then we've got to assume that all these, the vaccine that's effective has to then go into widespread manufacture. There's 7.5 billion people on this planet. We've got to manufacture at a rapid rate an enormous number of vaccines. South Africa, as a lower middle income country, is going to have to stand in the pecking order and have to try and sort of scramble and fight with all other low and middle income countries against the global north.
Well, if the Oxford trial comes forward, which is the one we participate in, won't we get some preferential treatment?
Who will get preferential treatment? Will it be the people with multi-morbidity? Will it be the well-heeled who can afford to get it? Will the government be able to afford to buy in the order of 40 million vaccines for the vast majority of people who cannot afford their own vaccines? Will those vaccines be able to be delivered and administered in a public health campaign? What happens if we need 2 or 3 vaccines? What happens if the vaccine only has a 50 or 60% efficacy rate? So all of these things are very, very important. What's going to happen if the vaccines, if the virus mutates? What happens if the vaccine is only effective in a certain group of people, and older people are less able to develop an immune response as vaccines cause us to do? We don't know this. So I tend to be very cautious.
Are you suggesting, therefore, that a lot of there's too excessive a hype with regard to the vaccines at the moment? Is that what you're telling?
No, on the contrary, the vaccine hype is really important. We need to.
No. What I mean by that is the idea that, no, I mean by hype, the idea that, you listen to the news and, an ordinary layperson is entitled to think, oh, well, by the end of the year, early next year, we'll pop up to our GP, get a vaccine, and all will be well. You're saying that's not going to happen?
I think if we look at, for instance, let's just use the flu vaccines as an example in this country.
Yeah.
Flu vaccines, I think at its peak, the total number of flu vaccines administered in this country is about 2 million. That's in a population, once again, of between 50 and 60 million people. So we're talking about 3 to 4% of the population are getting access to these flu vaccines. Yeah. And those have been readily available. So where are we going to be able to get COVID vaccines to get 30 or 40 million people vaccinated?
So because we're running out of time, let me just come back to something. I mean, it does mean that there's got to be a serious behavioral, if I put it this way, compliance between now and the time we get a vaccine. Otherwise, we back to the replication of the scenario in other parts of the world. And I just for myself, and I get a sense of real anxiety about this. I mean, this morning I was walking on the mountain with my friends. People run past, no masks. You ask them about masks, with expletives, they tell you to go away. I mean, with that kind of attitude, which I find a particularly middle-class attitude, I have to add, I mean, it just scares me that we will, in fact, within a short while, be back to where we were. And then what do? We can't lock down.
I'm not sure whether we can't. We may have to go through rolling phases of lockdown and relaxation. At some point, people are going to have to make a decision as to say, well, we have to try and prevent further spread. As to trying to control people's behavior, well, we've tried to control people's behavior for millennia. We tell people they shouldn't smoke. We've had bans against smoking. We've had bans against alcohol. These things don't work. What we need to do is need to go through education. We need to work on behavior change by positive messaging. And there are going to be the odd number of people who are not going to wear masks. But then again, you go out and you see a lot of people wearing masks. We can't, unfortunately, control for people who want to have idiotic behavior and behave stupidly.
And you don't think, basically, kind of, if there were a number of high-profile fines given to people, that might help?
I think there's in any situation, one's going to have a carrot and a stick approach, that you're going to affect behavior change through positive messaging. And if people aren't going to adhere and comply to it, then yes, probably it will be important to police things.
So just coming back to that, this idea that as you spoke earlier about other countries getting it yet again, is that just an inevitability because of human behavior and because this virus is as pernicious as it is, that we just got to accept that we're going to be living with this for quite some long while?
Dennis, we're going to be living with this virus forever. We're not going to wake up in 6 months' time and the virus has gone away. That's not the way viruses behave. The flu virus has been with humankind for thousands of years. Pretty much every virus that we know has been with us, other than eradication of a small number of viruses such as smallpox. Viruses are with us. They live with us. What at best we may see is that the virus may attenuate itself over time because it's in the virus's interest. It sounds bizarre that we give some sort of anthropomorphic concept of what a virus is.
Are you talking about Dawkins' approach to this sort of thing?
Yes, the virus. It's not in the virus's interest to kill its host, and over time, the virus will probably become less infectious and possibly less harmful in terms of its effect. No doubt, it will kill some people. We know that, for instance, flu does kill between 400 and 600,000 people annually in the world. So viruses do change over time. They come to live with us and we come to live with them. But this virus is not going away.
So because I'm running out of time, I want to circle back to your home and to aged people. Given what you've just said, how do you give old people hope? I mean, there they are in their 80s and 90s. So at best, they're going to live for another 5-10 years. I mean, living in a lockdown way must be horrible. What kind of, in your dialogue with them, how do they cope with this?
Well, you're making the immediate assumption that those people who are living in care facilities who are locked down are having a terrible life.
I'm not saying that. I'm saying, but they're not having the life they had before.
No, but no one is having the life they had before.
I understand that, but if you're 30, you can ride this out. If you're 90, there's nothing to ride out because you'd like to live your last few years in the most normal way you can.
And what does normal look like?
Most people know, but I'm saying going back to the status quo ante. If you're 90, you'd like to be able to wander around in the garden and perhaps go and have a cup of coffee with your friends in the coffee bar at the facility or whatever the case may be. I don't know.
And yes, you can. But once again, with the facility becomes a microcosm of society, in that when there is an outbreak within the facility, we need to go into quarantine and put people into quarantine again and then relax it. The biggest issue is...
Do they understand that?
Overwhelmingly, yes. The people who are living in the facility have, by and large, been very positive about it. There is a certain sense of disgruntlement and a certain sense of fear. However, living in a facility as the one where I'm working at, if you're an older person who's very fearful of going out and you live in an apartment block in a middle-class neighborhood and your greatest fear is going out and getting COVID, you choose not to go to the shopping mall to buy your loaf of bread and your milk. You don't see any of your friends. You don't have any social contact, and your family, and you're very afraid of your family coming to visit you because there may be grandchildren who need to come and visit, etc. So your life has become very restricted anyway. Within a facility, at least you can communicate and be with people who are like-minded, who are socially...
But you can't see your children because they can't come in.
Well, at this point you can't, but that's government regulation that prevents you.
No, I know that, but hell, that's a massive change for old people.
one considers whether the old people who are in these facilities had their families visiting. There are, unfortunately, many people who live in residential care facilities seldom have families visiting. We would love to know that families came to visit. We also need to know that many people who live in care facilities, older people have children living in all over the world. Whether, you know, older people living in the Transkei have families in the Eastern Cape or have families in Cape Town. They don't see their families on a day-to-day basis or week-to-week basis. They may see them once a year. Now we're faced with the issue of people saying, but I can't see my mother or my grandfather or whoever. But we ask, well, there are many people who live in facilities who have children overseas, and they don't see them but for every 2 years. So it's a really difficult thing, and it's horrible. It's horrible that people can't visit their families. And hopefully over time this can change. And we need to find some safe way of allowing it to happen. And certainly as soon as the restrictions are reduced and we can be certain that the risk of transmission is reduced, we would welcome people coming to visit their family members in the home. And it is horrible because many of the facilities have been in complete lockdown for more than 5 months now.
I've run out of time. I suppose I should say to you, I feel you've given me a cold shower, because this is a very, I mean, I'm not suggesting it's inaccurate, it's a very realistic picture, but it does show, it seems to me, that we've got a lot of education ahead of us, and we need to have a realistic approach to this entire virus. It's, as you say, it's not going to go away in a hurry. And I only wish that people would take it more seriously, particularly younger people, who really owe it to the older people not to run around without masks and behave in a cavalier fashion. But, and may I say, again, congratulations for what you've done. And hopefully that particular model can be used elsewhere so that other aged facilities can have the same success that you've had. Thank you very much, Leon.
Thank you very much.